Alrighty, everybody, welcome to the webinar. I'm Dr. Stephen Phelan. I'm here with Dr. Newton Fall. Newton, how are you today?
Hey, Stephen, how are you? Glad to
I'm
be here, man.
awesome, awesome. So I'm in Canada. Newton is in uh, Brazil. Can you guys let us know if you can see our screen and hear us and everything's okay? Jacob and Jennifer, maybe just text me and make sure that I know that everything is good with this so we can get started. Maybe everybody could tell us where you're here from in the world. I know there's people, you know, all over the world on these, so that's always really cool. So we have Dr. Newton Fall talking about composite resin veneers today, and you guys are in for a treat. Like, if you haven't seen Dr. Fall, it's like a really cool experience to see what can be done, pushing the limits of composite resin technology and artistry, really. I'll tell you a story. I first listened to and discovered Dr. Fall at the AACD meeting in Puerto Rico in 1997. So it's almost 30 years ago. I went, that was my first AACD meeting. I was a young dentist, and I went because I wanted to do the accreditation process. And my goal was to get accredited the next year, but I needed to learn how to do composites properly because there's two composite cases, one veneer case, one class 4, complex class 4. So I signed up for a bunch of lectures on composites, and I went to one by this guy from Brazil, Newton Fall, and I was like blown away. I'm like, what the heck is this? How do you do that with composite? You know, you got to remember, this was 97. We didn't have a phone then like this. We didn't have Instagram. We didn't have Facebook. We didn't have YouTube. We barely had internet. We didn't really have exposure to what could be done because it just wasn't out there. You had to go to meetings. So, you know, I remember the year before I went to a meeting with Dr. Coys, and I was blown away by what could be done with fixed restorative. And I went through the Coys program. But, you know, composite, I just didn't know you could do that. And so it was incredible. I did his hands-on course at Puerto Rico, which I'm lucky I got into because it was very sold out. And I learned, the beauty of it is you'll see this today and you'll be like, wow, this is incredible, but can I do it? The thing is, he breaks it down into systems, and it's like a recipe or a cookbook on how to do composites. And it actually makes sense. You know, I remember Herculate XRV in Sisal, Newton. That was one of the nicest materials ever for opalescence. And I followed his cookbook, his recipe. It was inspired by seeing his presentation, and I was able to do my composite veneer case. And I passed AACD accreditation, all 5 cases the first time. The next year I think it was San Antonio. So thank you for that, Newton. You were like my inspiration for composites back in the 90s, which is crazy that now we have you on a webinar with us. And so this is great for everybody. You know, do you remember that meeting, Newton? It was really a cool location. I wish they'd go back there.
I remember it totally. And I remember the location was fantastic. Puerto Rico is awesome. And, and just going back to what you said, you know, back then we didn't have a lot to work with. And you mentioned XRV Herculite, and it was one of the few composites we had available that was very strong and beautiful, like you said. But we could do a lot with it, and Durafil, you know, the only microfill aside from re-enamel microfill that we had at the time, but we could do miracles at the time, and boy, have we evolved from back then, and what we have available today in terms of technology and how we have perfected the artistry that's possible with composites. Just amazing. It's just amazing.
Yeah, I'm really looking forward to those of you who have never seen Dr. Fall's presentations. It's going to be great for you. And those of you that have seen them, you know, this is a new topic and a new technique. that he's going to be showing regarding composite veneers. So we've got the traditional technique and we've got this indirect direct technique. And this is what I wanted people to see because it's kind of inspired me back into the idea of doing composite veneers because, well, I'll tell you about my ACD accreditation case later, but it can be a traumatic experience trying to achieve perfection directly in the patient's mouth. It's not the easiest thing. So anyway, I think I'm going to leave and let you go ahead with the presentation. I saw a glimpse of the slides, everybody. He's got a phenomenal presentation. He's going to be over delivering with a large amount of value here today. So make sure you stick around. We will do Q&A at the end of the webinar. So if you have any questions, by all means, type them in the question section of the control panel. And I'm going to do my best to ask all of the questions to Dr. Fall at the end of the webinar. And if we have time, we even have a little bonus case study that we're thinking of putting up. So I have it here, and we might do that. Depends on how much time we have and how many questions we have. We do want to get through the questions. So thanks so much, Newton. I think we'll drop the webcams now, maybe bring them back when we do Q&A, and start right into your presentation.
Beautiful. All right, then. Okay. Thank you so very much again, Stephen, for having me back. And thanks, everybody, for being here from all over the world. Now, let's get on with it. We're going to talk about composite resin veneers. And the question is, should I make them direct or indirect? And we're going to be addressing some of the direct approaches, the rationale for it, when to do them, and also the novelty called direct indirect approach, which I will lay out to you in more detail a little further down. So there are differences that are very pertinent and very interesting that I think everybody should be aware of in order to incorporate both techniques into their practice. Now, the first thing here that we need to be aware of is that any composite restoration we do has to do about details. Form, color is part of it. And the importance of anatomy cannot be overly stressed. For instance, I went on a trip to Taiwan one day, and I went to a museum, and there was this origami section that just blew me totally away. I saw this piece of art which blew my mind because it was just one single sheet of paper folded in such a way that it could give me a three-dimensionality with one single color of paper that really made me think, my goodness, it's all about composites. And it's not about layering with multiple shades, but it's how I can be perfect in my anatomy and get the fine anatomy even with just one shade. For instance, this young lady comes to me after orthodontics and she wants to have me work on her smile, right? So we talk about shape because it's pretty much about shape here. She has diastemas, and we talk about anatomic proportion, how the central, the lateral, and the canine should come together in terms of their proportions. And then we look at the ortho. We talk to the orthodontist and finalizing the case where the teeth should be in the arch. And after that, obviously, after removing the brackets, we bleach to make the teeth lighter. And then we talk about digital planning. So we talk about how we want to go about choosing the right shape for her. So I talked to her and she goes, I really don't know what kind of shape I like. So I present her with a multitude of possibilities. Do you want teeth to be triangular? Do you want them to be oval? Do you want them to be square? She goes, I like them oval. But I said, what kind of oval do you like? There are different types of oval anatomies to choose from. So I take her over through, the templates that I have. She picks that kind of oval. So what do? I take a single shade of composite, I mock it up, I rearrange the anatomy. She approves of it. You see, one single shade of composite. This is not fancy layering whatsoever, just to get the anatomy down right. She approves of it. Then I just go in. This is a very simple step, and I believe most of you, if not all of you, already do it. But we take bite registration material, get an imprint, and from that imprint, I am able to now visualize the anatomy that was pre-approved by the patient, and I can go in and do my final layering. And just so that you know, I used one single shade of composite for the incisal edge buildup and for the veneering. So very simple approach, focused on anatomy, but resulting in a perfect color outcome. Perfect. Now, going back to the importance of anatomy, if you look at this case, a young patient in his late 20s, Bruxer, he wears down his incisal edge, and the anatomy is good. The shape is not bad, but he's wearing the incisal edge. What do we do here? The same concept. It's not about color. This is about form. So I choose one single shade of composite, mark it up, check my occlusion, my canine guidance, anterior guidance, do the same drill, take an impression. Now I know how much to add. And in this particular case, I used 2 shades of composite, one dentin shade, one enamel shade, and I layer them sequentially, and I was able to achieve the right shape and obviously the right function based on my treatment planning on my mock-up. So that's the beauty of us understanding where we can go with composites in terms of reestablishing the proper shape. The shade is secondary to the shape. Not meaning to say that it's not important. It is, and we'll talk about it. But if we understand the importance of our primary anatomy, then line angles, point angles, and embrasure forms, this is all coming together in the layering that we will do later with our actual composite. Now, the question we must ask ourselves is, why do I need to do, or why should I do a composite direct veneer? Number one, it can be minimally invasive, hardly any preparation, or if you need, it can be conservative in some cases. It requires the mastery of the technique. You have to be knowledgeable about it. You can do them rather quickly, provided you follow a strict protocol. They can be financially rewarding if you understand the value that is aggregated and the patient understands the same. The aesthetics is absolutely gorgeous, and it rivals, if it not surpasses porcelain in some situations. Longevity, it's a relative longevity. We'll talk about that, but it's perfect for cases where you want for young adults. And then there is the personal and professional satisfaction that we as operators get from being the perpetrators of the actual artwork that we're doing. Now, direct veneers can be used for changing the form, for changing the color, and for changing both the form and the color of restorations. Let's take this case, for instance. This is hypoplastic enamel, not a major discoloration, but needing to be resurfaced. So what do we do in a situation like this? Is there a dark color that needs to be veneered and opaqued out? Not really. The problem here lies in the enamel, which means I can be extremely conservative in my preparation, just removing the extraneous, the outside enamel, let's say 0.3, 0.4 millimeters, and then just go back and do my layering directly with maybe a body enamel, a fat enamels, to get the nice transition that we see from cervical to incisal. Again, the beauty of composite here is that the preparation is very conservative, and you can use 2 shades to get the transition, the color transition that you want. And here we can see the very same case 1 week later with beautiful margins, beautiful gingival restoration integration. And this is another follow-up 11 months down the road. Okay, so let's take a look at a direct case and when I would indicate a direct veneer. This is a dentist patient who comes to me in her early 30s. She had already had some composite veneers in the past, and they were now showing some defects, some staining and discoloration, and she wanted me to redo them for her. And being a dentist, we discussed the possibility of doing porcelain veneers, and she said, no, I think we can go with composites because they are extremely conservative, and I wouldn't want to prep my teeth any other than just that which is necessary for me to reestablish the proper form and color. She was lacking incisal edge display, So we decided to go ahead and do a little planning, which involved increasing the incisal edge and also veneering the facial to increase the emergence profile and the facial planes, because the teeth were slightly in the buccal lingual inclination, right? So what we're doing here is adding a very thin layer of composite to the facial and adding a little bit to the incisal. So what do I do in cases like this? I do a mock-up, in this case a little more elaborate, so she can approve not only the shape but also the color and look at the function as well. So we check our protrusive, our canine guidance, we approve of the layering, and then it's just a matter of removing the mock-up and prepping just enough to allow room for my layering. Very minor preparation in this particular case. I'd say about a millimeter and a half incisally and about half a millimeter to 0.7 millimeter on the facial. And then I do my layering according to the shades that we selected. Now I can play with as many shades as necessary to achieve the polychromicity. For instance, I can do a higher chroma body enamel on the cervical. I can decrease the chroma towards the middle third. I can increase the value of the lobe so I get a 3D color perspective from the lobe to the center of the tooth. I can put in dentin mamelons with the actual composite and with tints. I can add translucency with tints or even with translucent enamel shades. And I can finalize my layering with what we call a value enamel. We'll talk more about that in a minute, okay? So I usually start with both central, so I get the dominance and the smile. I check my function to see if everything's right. And then I start working the distribution of anatomy and proportions, and I talk about where I want my line angles to be, the point angles to be, how closed or how open the embrasures should be, and I just go in and I finalize the case. Obviously, all of this was previously discussed with the patient to get her approval in terms of what sort of color and form she wanted. And this is right after I got done. You can tell the teeth are not bright or not really bleached white because she didn't want overly bright teeth, but they are in accordance with the actual color she had on her opposing arch, and that blended so very nicely and very polychromatically. And according to my planning, I was able to get the incisal edge position, embrasure form, my negative spaces in the right shape where we wanted to be with this conservative approach. So this is a particular case where the direct veneering would be indicated because of the minimally invasiveness of the preparation, my ability to do a polychromatic layering according to the actual existing shade, and we were able to change her from that perspective to that perspective. Now, this is a nice case because she, being a dentist, really followed up on her care and hygiene, and everything is looking really nice up until today. And I'll show you a picture a little later on. We were able to reestablish a beautiful incisal edge position with tooth display, a beautiful smile according to her smile frame, and this is what it looked like when we got done. Now, this is the pre-op and the post-op. And now, 10 years later, this is what it looks like. If you look on the right screen, we have a little bit of a wear of these veneers. So she comes to me and asks me, what do you think we should do about these veneers? And I said, well, what do you think, being a dentist patient, that we should do? She goes, well, I think they've lost a little bit of their secondary anatomy, and she was referring to the terminology for obvious reasons. But I like the color. I don't think we lost the function. I don't think we lost incisal edge length, and I wouldn't do anything. And I said, well, I agree with you. Oh, I wouldn't do anything at all because I think 10 years is a pretty good time span for composite veneers, and we need to take into account the fact that composites, being polymers, will undergo some sort of morphology or surface morphology loss over time. They may discolor over time as well, such as in this case. So this is a patient, young patient in her early 20s. I did some crown lengthening and bleaching for her, and I did the veneering. And 20 years down the road, she comes back in, and this is what they look like. And remember, these are old composites. This is a very old case. My final layer here is Durafil VS, which is an old microfill composite. So this is a case where we were discussing now maybe resurfacing, re-veneering the case by merely addressing the outer part of the tooth without having to remove everything, especially because we have peg lead rows, right? If the foundation is good, we're just going to leave it like that and we'll resurface it. And I was very curious about the longevity of cars, just to compare that with the longevity of composites. And I went online, and there's actually statistics, can you think, about how long a car lasts before it goes to the junkyard. And one of the statistics shows that a car usually lasts for about 200,000, 300,000 miles, which is a lifespan of 12 years. And I said, oh, my goodness, if a car that costs a lot of money lasts 12 years, why would my veneers need to last longer than that? We don't have the obligation to tell our patients that they should expect composite veneers to last any longer than 10 years, although some cases they will look pretty good at 15 years or even at 20 years. So the analogy I use is this. I have this 1965 Beetle. I love my Beetle, right? So I bought it almost finished. It was refurbished. So I was about 95% done, but the foundation was pretty good. So what I did here was I refurbished my 1965 car to last a long time. It looks like brand new, but the foundation is good. So which brings me to the direct composite survival question. How do I continue to preserve the longevity or to push the lifespan of a composite that has a good solid foundation? Let's take a look at this case. This happens to be my niece at 26 years old. She has a seizure. She falls down the stairways. She breaks her central and lateral. She comes in. This is July 2008. And I fix her teeth, right? It's a transsurgical restoration. I need to raise a flap, bond the fragments back in, and do my buildup. It's not a veneer, it's a class 4, but nonetheless, it's a composite restoration. So she comes back in, and it looks like this after 45 days. It's looking pretty good. Tooth vitality is good. 1 year down the road, that's what it looks like. So it's looking pretty good. Now, what do we have here? At 2 years, periodontium is looking good. The aesthetics is looking good. Now it's starting to show a little bit of dulling of the polish because I used in her case a hybrid composite which does not retain the luster like a microfill or a super nano filler does. So 8 years down the road, she comes in, pulp vitality is good, periodontal health is good, but it's now starting to show some wear and she's complaining about it. So she wants me to do something about it. So what do? I just go back in, I do a minor facial reduction, and then I do some sandblasting with silica ceramic or any aluminum oxide will do. I can just etch, apply phosphoric acid, and then silanate. I can use a TEM and MDP based composite for better bond. And then I do my composite layering just the regular way, the way I would do it. My veneering, I actually did a veneer cervical and middle third using 2 shades, a body enamel and the value enamel. And I'm back to my original anatomy and I'm back to my original aesthetics, meaning I am continuing to preserve the longevity of these restorations because the foundation was pretty good. Now, after some time, she comes back. This is 8 years. She comes back now after 16 years, and now the teeth are starting to show a little bit of degradation, and there is minor tissue recession on number 10, and she's complaining about the breakdown of the margins. And I talked to her. I said, listen, this is still looking pretty good. All I'm going to do here is a little polish, and I'm bringing your tooth back to the original anatomy, original gloss and shade that it had. If farther down the road it needs to be refurbished, we'll just go back and do the same thing over again. So my point here is composite veneers can last a long, long time, provided there's a solid foundation, which is based on proper adhesion, proper light curing, proper finishing and polishing, and obviously home care, including dietary habits, non-acidic intake of food and beverages, which will help. And obviously, your toothpaste and the way the patient will take care of that will help to promote a longer lasting restoration. Now, the question you may be asking yourself now is, which composite is best? There are so many composite availables on the market, and last I checked, there were over 70 types of systems available, which makes the selection pretty daunting. But I want to refer to Jack Ferrakine's article, and I'm going to quote, "There is no ideal material available to the clinician, but all of them, if they're properly executed and used, are available or are able to deliver excellent clinical outcomes of adequate longevity." So I subscribe to that. But in order for this to get longevity, we need to understand there are microfills, hybrids, and nanofillers, each category having a different type of behavior clinically because of the chemistry, right? So you may have, depending on the material, different sculptability, fracture toughness, wear resistant, polishability, color stability. And if you look at microfills, they're excellent in terms of sculptability. They're great in terms of polish, but they're not strong. If you look at hybrids, they are the ideal materials in terms of strength for incisal ledge buildups mainly, but they have other properties that vary in terms of performance depending on the generation and the brand. If you go to nanofillers, supra and clustered, it's pretty much the same like microfills, and it'll vary slightly, being very polishable, but not as strong for like wear cases or ruxers. You have to combine hybrids with microfills or supra nanofillers or nanofillers to get the best of each world. You also have what we call the omnichromatic shades like omnichroma and other types of materials like Athentia, and they will provide you with a single colorless shade, a single shade that is supposed to do it all. And I'll talk a little more about that. Now, when it comes to the layering techniques that we use for our veneers, you go to any article that talks about layering, you'll see a different type of layering approach. But basically, they are both based on two types of approaches. One is the polychromatic layering, and the other is the natural layering approach, one by Didier Dici and the other one by Fall. Now, we are always looking at the replication of the polychromatic nuances that we see on a natural tooth, from cervical to incision, and all the variations that we see in hue, chroma, value, translucency, etc. And that's what we need to go by when we select our composites. So for each type of layering approach, you have different types of systems according to the shading designation, right? So you have here a system that will be more suitable for the natural layering approach or the 5 dimensions of the tube, which is Lorenzo Vanini's approach. My technique, which is the polychromatic, uses about 98% of the systems available on the market, and I'll tell you why in a minute, but mainly because we can use any shade to get the result we want, provided the system is comprehensive. Now, again, we're going back to enamel and dentin thicknesses, and we're trying to correlate that with the actual layering that we do. So that brings us to the polychromatic layering technique, which I published in 1995. And what I did there was to correlate the biomechanical properties of dentin and enamel with the actual properties of current composites at the time, including optical properties, and coming up with a way where we could build up an entire tooth according to these properties. Now, 25 years later, I published this article with Weber Ritzy, where we revisited the concept, and this is available for you to have access to later on if you want. Now, we really take this to the next level, and we discussed fluorescence, different levels of opacity, and we did some studies looking at that and what materials really will be able to give us the properties that are relevant for each layer and for each part of the tooth that we're building up, be it a total buildup or a veneer. So with the polychromatic layering, when we have 4 shades of enamel and shade of dentin, and that when brought together create that polychromicity, we need to understand which what each layer will entail. For instance, a milky white semi-translucent enamel will create a lingual shell. It should be a very strong, preferably a hybrid composite. The dentin should be a hybrid of higher opacity and higher color saturation. Then we have the opalescent enamel, I call it trans enamel, to provide that inner opalescence. Then there's the body enamel, a Vita-based enamel that is applied mainly on the cervical and middle thirds, phasing out towards the incisal 1/3, to be then covered by a value enamel, a non-Vita, achromatic enamel that gives me that beautiful incisal characterization. So when you do the polychromatic layering with all 5 shades, you get a beautiful buildup, like in this case. And you go step by step from 1-5, you should be able to build an entire tooth just like you would a ceramic crown. Now, a veneer does not use a lot of dentin. It will use a dentin somehow, but to a lesser extent, right? So you don't have to use all shades all the time. It really depends on the level of translucency and incisal characterization that you have. Sometimes you have to use 2 shades, sometimes 3, sometimes 4, sometimes more, depending really on the challenge. Maybe sometimes just a little bit of enamel, maybe a little bit of dentin and a couple of enamels, or even more shades of dentin and more shades of enamel. It really is dependent upon the case at hand. Now, natural layering, DDA's technique, uses a different approach from the polychromatic, in which the enamels are achromatic and they change in value from the young dentition to the elderly dentition. And he developed this system called Inspiro, available in Europe only. And this is based on his technique. But you can use other systems for the natural layering, for veneering, and for building up. For instance, this is Vital Essence from Ultradent. And I can use the achromatic enamels to veneer and modulate the value and the chroma, just like we see, excuse me, in the natural dentition. It's a beautiful system, and there are other systems that allows me to do my veneers and create enamel-like layers on the outside. Now, this is a good case for a direct approach. Patient comes in with a missing lateral or central incisor, which she lost from a bike accident. So what we did here was we looked at reestablishing the proper morphology by adding enough material to recreate the contact and the distance between the interproximal contact and the bone to get a nice contour, gingival embrasure, and not to have a black triangle. So I do my digital planning here, and I do a wax up. Obviously, we're in a digital era where you can do your scanning, you can do your digital planning, your exocad, but I still do a lot of waxing up. So from the wax up, I can plan where I'm going to go with my surgery, which I did to increase the ratio, and then you can do your layering. This is the ideal case for a direct veneer, in which you're changing the form and you're bit by bit adding the layers to recreate the shape and the shade, right? So why is this a good case for a direct approach? Because you can add bit by bit to the tooth according to the different thicknesses that you want. And different teeth call for different thicknesses and shapes of layers. This is a great situation for a direct veneering approach, like you see here on the screen. Now, that's why I see composites being an excellent and ideal materials for situations such as this, because it gives us, the operators, the control over form and the color that we're getting at the end. Now, the direct-indirect concept, folks, is a little different from the direct approach. What is the direct-indirect veneering protocol? What are they? In a nutshell, they are what can also be called semi-direct. You will see in the literature the terminology semi-direct. I do not comply with that, nor do I subscribe to that term, because semi-direct entails something that is half, and it describes half of what it means, but it does not describe the other half of what it means. It's okay to call it semi-direct, and I respect those who do, but I coined a term which is direct indirect because the restoration is directly sculpted on a tooth without etching and bonding, polymerized, and then it is removed, flaked off, finished, polished, heat tempered, and then it is indirectly bonded. Hence the name direct indirect. Directly sculpted, indirectly bonded. The idea is not mine. I came across the concept when I read the article from Dr. Nathan Birnbaum from New York, from Boston actually. And in 1992, I was in awe of the benefits of the procedure because it gave me the ability to visualize my final shape and shade prior to luting, prior to bonding. And I started to evolve and develop new concepts until I published an article in 1996, primarily dedicated to the treatment of the single discolored central incisor. And I'll talk more about that in a minute with you. But this is one of the key indications for a direct indirect veneer. When you have a hard time getting a central to look right, how many times do we do a single veneer on a discolored central and we end up not having the right color or the right shape, and we need to get the patient back in and redo it? That's why I started to work with this technique. Not only that, 30 years down the road, I published this book by Quintessence, published by Quintessence with my good friend Andre Ritter, and it's called Composite Veneers, the direct indirect technique, in which we describe the concept, the resins, the layering strategies, what contact lenses and veneers are, veneers with preparation on dark teeth, the indirect restoration on models, which I'll talk a little bit about here, and the class 5 inlays for non-carious cervical lesions. Now, this is a fantastic book that if you want to get a hold of, I would encourage you to read because it has a lot of fantastic, very pertinent information in it. So we talk about the direct indirect concept in full detail. That's one chapter. And even in a world where we're looking at digital dentistry, how can we conceive spending time doing these veneers, because we have the ability to scan so quickly, to come up with exocutting protocols that will, go to the camming, to the manufacturing process so quickly. And I know a lot of people have totally gone at 100% digital. I think it's okay, but I think sometimes it may end up being an overkill. My opinion, folks, my opinion is I think there is room for everything here. There is room for digital and there is room for analog. I am an analog man in the digital world, and I try to hybridize both in my day-to-day practice. So let me talk to you about where I see ceramic veneers coming into play, right? Not talking about the direct indirect. If you look at the literature, there are several studies that will come to the conclusion. We're talking about meta-analysis here. They all will be unison in saying and stating that porcelain veneers have a longer lifespan than composite veneers. That's not new. And why is that non-new? Because ceramic is ceramics and composite is composite. But we are not to compare apples and oranges. We have to understand where composites come into place and where composite veneers, direct or direct indirect, come into place. So let's take a look at this case. I did 6 composite veneers on her. She was 19 years old. Now she's 36 years old. These restorations are wearing down. They're losing surface texture and color. And now she is a veterinarian, 36 years old, and she wants me to do porcelain veneers. She can't afford them. The teeth had already been prepared, so I'm not doing anything invasive. So we decide just to go ahead and comply with her request, considering her financial possibility. And we do feldspathic porcelain veneers for her done by Murillo Calgaro. That's the perfect indication for ceramic veneers. Beautiful case, feldspathic veneers, life looking, and she could afford them. She wanted them. The teeth had already been prepared. So that's the perfect indication. What are the other indications for ceramic veneers? When you're doing multiple units and you are not really familiar with the protocol for composite veneering. If the patient is a smoker, it's a no-no for composites because they will stain in about 3 years. Dietary habits, acidic food and beverages intake, desire for longevity. If you're talking about longevity intrinsically, yes, porcelain will outlast composites, but there are other ways they will fail, as I will talk about a little later. And if cost is not a factor, because porcelain veneers will obviously entail a laboratory fee that you must include in your fee in order for the patient to be able to afford the treatment, right? Well, this is the porcelain veneer, a patient of mine who had done these veneers with another dentist, done by another dentist. These are Emax veneers. And she comes to me saying that teeth number 8 and 9 had huge gaps underneath them and they were leaking, they were staining. Well, I happen to have a YAG Urban laser. So what I do here, I just pop the 2 veneers out. And what I do here is I go back and I retreat them, the intaglio, and I go back and I bond them back in. So in other words, I am furthering the longevity of these ceramic veneers because I am able to retrieve them and bond them back. So even porcelain veneers, when they start to fail, however way they will, I can try and provide a longer lasting lifespan to them. So this is what it looked like when she comes back for a follow-up. And this is what I would like to have done, changing the tissue profile, but then I would need to redo the veneer and not just bond it back again. So I send her away. Now, why would I even consider doing indirect veneers? Here are the facts. Number 1, marginal adaptation. You see, it's fantastic. It's out of this world. Marginal polish, because you do everything extraorally. Periodontal health, because you have better marginal adaptation, better polish. Subsequently, you have a better periodontal health. The mechanical and optical properties are further enhanced because you do heat tempering and supplemental light curing, extraoral light curing. You're able to do some shade try-in to modify the color prior to luting, giving you chances for correction. You do them in one appointment only, and there is a cost which you can take into account the fact that you're not doing this in the lab and reduce a lab fee. I usually charge the same that I would for a porcelain veneer minus the lab fee. I'll say that again. I charge the same that I would for a porcelain veneer minus the lab fee, which makes the direct indirect veneers more affordable to the patient. Now, there are 10 steps that we go by to do a direct indirect veneer, from shade selection, application of the composite, intraoral light activation, restoration removal, supplemental extraoral light curing to further enhance the conversion of polymer, heat tempering, extra and intraoral finishing, extraoral polishing, shade try-in, and the final luting. So these 10 steps are part of the protocol that can be applied to both veneers and even class 5s for non-cervical carious lesions. So when we talk about veneers, I need to create a subdivision here because veneers is like a common term for anything that covers the facial aspect. I further subdivide the concept into two categories. A contact lens, which is a very thin veneer ranging anywhere between zero point 0.2 and 0.5 millimeter. You'll see why we like them. And then a veneer, which is about 0.5 up to 1.5, which will require not only enamel shades, but also enamel and dentin shades. Now, the beauty of a contact lens is that it has that ocular contact lens effect, picking up the underlying to substrate color and also giving you the ability to modulate the shade to some extent when you're luting it, very much like you do with a more translucent either Emax or feldspathic veneer. Here's one such case for a contact lens, a slightly lingually positioned central incisor. And what I do here is just a very simple direct, indirect contact lens using one single shade of composite. Very simple. It takes me 12 minutes to do this. Now, and there are very many ways you can layer, and this is from my book, and we can have incisal edge modification or not, and you can use one body enamel, one value enamel, or a combination thereof. Here's another case where I'm doing a contact lens using a single body enamel. You see these two central incisors are offset, they're lingually positioned. The patient wanted them further out and lighter because they were dark. So with one single shade of composite, I was able in one single appointment to get them in. Now, you can have contact lenses that require incisal edge addition, augmentation. In this case, you're going to need to have a stronger, a hybrid material for that. And all the layering is according to the previous concept. Now, this is a patient of mine who wanted the centrals to be fixed prior to her daughter's wedding the next week. And she has some acidic wear and incisal wear, so she grinds a little bit. I use two shades, a hybrid for the incisal and a supranano filler for the facial, and I can do this in about 45 minutes. She's ready to go home. Very simple. Here's one case in which I can show you the benefits of the contact lens. A post-ortho case with a peg lateral, heteromorphic lateral. We bleach, and after bleaching, I decide I want to use one incisal hybrid composite with two shades of microfills. So I'm combining supranano fillers with microfills for the veneering of this case. And this is after I removed, finished, and polished. They're extremely thin, as you can see here. And the beauty here, folks, is not only do I have a wonderful marginal adaptation and finish, I can do try-in. And that try-in allows me to decide whether I want to raise the value, increase the chroma. Whereas if I had done these directly and I had gone wrong with my shade selection, which may happen, I wouldn't have the ability to modulate the shade. Meaning I would need to get the patient back in, or on the same appointment, I would need to prep these veneers back and then just go back and redo them, which makes me lose face, and the patient doesn't like that. So this is the actual luting after luting. And I want to call your attention upon not only the color integration, but look at the tissue restoration integration, which is one of the greatest benefits of this technique. Look at the margin. And I ask you, when was the last time you got a tissue restoration integration of this sort with your direct veneer? Oftentimes, more often than not, we get a tissue that is scared from the burr, from our finishing, the scalpel, what have you. You never get that kind of result, which is immediate post-op. Another sequence for you to appraise. A patient comes in, and she wants me to do a simple veneer on her lateral, right? So what do I do here? I do a shade selection according to that technique, and then I do my layering. So I use as many shades as necessary, body enamel, value enamel, dentin shades. This is not different from the direct veneering shade selection. What's different is the layering that I do, because I do the layering sequentially. Light cure, remove it, I flake it off, I outline the margins. I do my finishing extraordinarily to allow me to get perfect margins, perfect polish of the margins. And then it gives me the ability to take this very thin veneer or contact lens and try the shade in to see if there is any color modification that I want. In this particular case, there was nothing that I needed to do. In addition to that, I do my supplemental light curing. I can light cure for 30 seconds, 1 minute, giving the utmost joules energy to promote the conversion from polymer to monomer to polymer. And then I can do heat tempering either with an oven for 10 minutes, 120 degrees, or with a microwave for 3 minutes set at 450 watts. This increases the polymer conversion, makes the veneer stronger, decreases water absorption, and overall improves the color stability. And then you go ahead and do your surface intaglio treatment with sandblasting. You silanate, you mix or you select the shades you want, and then you just go back in and you do your bonding according to the shade you want it to do. And this is the immediate post-op on the left. On the right, you have after rehydration, and you can see a beautiful integration of color and form. Now, look at this case. This is an awesome case, folks. This is when the direct indirect contact lens is primarily indicated. A 16-year-old young lady after orthodontics, she wanted me to do an upgrade on her smile. She wanted the teeth lighter and slightly fuller. She even talked about porcelain veneers. I said, no way. You're 16 years old. I will not touch your teeth with a burr, and I will not do prepless ceramic veneers because I don't subscribe to that. I think there is a potential for ledges, marginal ledges, which will, with time, create some periodontal problems. So you are the perfect case for bleaching and then for direct indirect contact lenses. She had pretty good occlusion. So what we did here, we looked at where we wanted to go with an intraoral mock-up. From the mock-up, I took an impression, and then I started to do one tooth at a time. I used only two shades, two shades. One enamel shade, which was polishable on the facial, and a strong one on the incisal. I do the two centrals, and then I do the laterals, and then I do the canines. Now, a case like this takes me about a good hour and a half to do the veneers, and then I'm ready to bond. Okay. Now, what's so beautiful about these direct indirect contact lenses? They are extremely thin, 0.18 millimeter thin. So it's awesome, the ability that we have to change the shape, and now with the try-in, change the shade if necessary. Maybe we wanted to change the value, which in her particular case, she wanted me to change the value. When I got done with the contact lenses, she says, Dr. Fall, I like them very much, but can you make them brighter? Can you make them lighter? I said, oh my goodness. Aren't I glad I did direct indirect, because I'm able to now use a higher opacity luting resin and change the value, which I did. And I tried it in, she approved of it, and then I went in and I bonded. This is the immediate post-op. She comes back the following day in the morning. Look at the tissue. Folks, look at the tissue. You can never get tissue to look like this with a direct veneer the following day. I know that much. So you check the occlusion, everything looking good. We had hardly any room for secondary anatomy, so we just went ahead and prescribed an acetate vacuum form splint, which I do for all my patients overnight for 90 days at least. And this is when she comes back after a year. What a beautiful result we were able to get. What an awesome result, as conservative as any procedure can be for a 16-year-old that wanted an upgrade on her smile with the direct indirect veneer. And folks, this is not only true in the hands of Dr. Newton Fall, who devised the technique. This is true in the hands of those who learn the technique and can implement the protocol effectively. This is Dr. Yokoda. She took my courses, and she's now doing a lot of direct, indirect veneers. It's amazing. She's taken it to the level of expertise that it's just unsurpassed. So anyone can learn this technique if you understand the concept and you follow through the protocol. Now, there are also other ways that we can use these veneering techniques and contact lenses. Most our composites are based on pigments, right? We have the yellow reddish pigments that give us the achromatic color space where the teeth lie. We know that. And we use this for the polychromatic ling. For class 4, for instance, the dentin has pigment-based composites. Enamels can be pigment-based. Enamels cannot be pigment-based. You can have the polychromatic results according to that. Now, if you have a tooth that is A1 and you choose an A1 shade, there's a good match. But if you have an A2 tooth and you use an A1 shade of composite, there is a mismatch. Now, with a structural color concept that is applied in some composites, and primarily, namely one, and I'll mention it now, you have what we call the structural color concept, where the color is based on nanostructures like butterfly wings and opal stones that produce different wavelengths of light, not based on pigments, right? So you can see this on butterfly wings. You can see this on guanine crystals, fish scales, and some composites, namely omnichroma from Tokuyama, will have these spherical particles, which we call photonic crystals, and they are gauged in their diameter to be able to promote the actual light transmission that picks up the reddish yellow wavelengths, which make this very lifelike. Because when you're doing your contact lens, the enamel is so thin that it will, the omnichroma composite and others similarly will have this beautiful reflection of the reddish, yellow reddish hues based on the way they change the light reflection. This is one such case in which I did the centrals with a direct approach because it was just minimal addition, augmentation. And then I used omnichroma for doing the contact lenses on the canines and the premolars. And they were so thin, you can appreciate what they look like here. It's almost like a glass. So what the beautiful nature of using omnichromatic composites such as omnichroma is that it picks up the underlying tooth color, altering the value to some extent, and it gives you that beautiful transition from cervical to incisal. So now you can see these contact lenses extremely thin being bonded. Now they're in position and you see a natural gradation in color, namely in the canine and the premolars from cervical to incisal using the omnichromatic concept, right? Now you can also apply this to other products. There is one by Ultradent called Transcend. It has some enamel that are based on similar technology, not the same, but they're similar. There's one called Universal Body, and there is enamel neutral, enamel white. And this is a case that I did using Transcend UB, enamel universal body. And what you see here are 4 contact lenses keeping the shade of the patient. We didn't do anything in terms of bleaching, so keeping the shade of the patient to preserve the color which he wanted and just change the shape. Now, there are other ways we can do these direct and indirect restorations. Let's take a look at veneers. Now, veneers, folks, is when you need to add a dentin shade underneath the enamel shade. Why? You need to add a dentin shade underneath of the enamel shade because you need opacity and you need chroma to prevent the lowering of the value if you go beyond 0.5 millimeter. And there are several ways you can do your layering. You can use the same concept in terms of enamel layering for the contact lenses, but you need to add a dentin shade underneath to increase the opacity and the chroma. Take a look at this case, the ideal case for a direct indirect veneer. This is a 26-year-old patient. She is in pre-med, and she comes to my office, and she wants me to do porcelain veneers on her peg laterals. And I asked her, why do you want me to do porcelain veneers for you? She goes, because I had them done 3 times before by different dentists. They always discolor, they always stain, they always chip. And I told her, what if you can leave here today? Today, one appointment. With new restorations in composite that will look so much better. She goes, how are going to take a putty because the anatomy is not so bad. And then I'm going to remove the old composite. And then I'm going to do a layering of the composites that I will select with your approval. And after selecting the shades that you approve of, the color that you approve, the shape that you approve, I'm going to go ahead and remove it, finish it, and I will try it in. And she goes, what does that mean? Well, that means you will be able to tell me if you like the shape, if you like the color, if you want any modification, which I can make. And if not, we're just going to go ahead and bond. And she goes, I love it, Dr. Fall. Let's go ahead and do it. And she loved it. Why did she love it? Because I did it in one appointment. I saved her some money from doing a porcelain veneer. And I tell you, the aesthetic result of that case with composites, in my opinion, is far superior to that or than that we would get with a porcelain veneer, which would require minor chamfering in terms of preparation. Now, we can do other types of direct and indirect veneering. This is a patient of mine who came in after many years of having the old composites that had worn down. In this case, I just removed the old composites and I made her direct and indirect veneers to change the shape and the color. So just so that you know some of the composites that you can use. I used a dent and shade of a hybrid for a lingual shell. I use, that was Empress Direct, Renamel Nano, this is Cosmodan D2 Hybrid for my backing. And I finished it up with Estelite Sigma Quick WE as a final achromatic enamel. So what's the beautiful part of this procedure is I make my restorations right there and then. The patient is approving of the shape, approving of the color. She goes, I love it, Dr. Fall. Let's go with it. Then I do the other central. We get the centrals to look the same. Then I move to the laterals. And then I move to the canines doing the class 5s. And what you see here is the end result after some time, preserving the natural color she had, which she wanted. And this is 8 months following up on what she had before. So what a beautiful case, what a beautiful result we were able to get with a direct, indirect approach. And I was able to talk to the patient. She was able to approve of it. I had fantastic margins, fantastic polish, fantastic polymer conversion because of the heat tempering and supplemental light curing, all the benefits in one appointment. Now, we can do other types of techniques as well. I'm just going to skip this and I'm going to go straight to the very final case we have here because I think it's the most important case that we can discuss, talking about the discolored restoration and the flexible dye. Now, there are situations, folks, in which you can do multiple teeth on a flexible dye. This patient comes from another town. She flies in an hour and a half away, and she has a melogenesis imperfecta. What do I do here? I simply do a direct mock-up in her mouth. I set aside a full morning for this, and then I take an impression of the mock-up, and then I take my impressions, I pour a flexible model to work on, and then I go in and I bond these indirect veneers in her mouth on the following day. So that gives me the ability to work in the left scenario, left setting on a bench, fixing the veneers, making the veneers as necessary to get the final shape. Now, the discolored tooth is also one that poses a tremendous challenge. This is one that when you get it right the first time with a direct approach, this is awesome because you get it right, patient doesn't complain, and this is a direct veneer. So I consider this a perfect case. But what if I had done it wrong, like I discussed before? Take a look at this case. This 18-year-old patient comes in with a dark central incisor. We bleach the other teeth, and then I need to veneer this tooth using an opaquer, a dentin shade, and enamel shades, right? Each layer providing a different type of characteristic of result, color result. So what we do here, we prep the tooth about 1 millimeter, 0.2 millimeter and a half. We have to prep, we polish, and then we do the layering just like we would for a direct veneer, except that what you do now is you have the ability to do a color check as you are doing the layering until you get the final veneer. You finish, you polish, and then you try it in. Now, when you try it in, the paint is right. And if it's not wrong, I have the ability to go in and bond. Now, if I had done this directly, what's going to happen is I need to go back and reprep this tooth and go back and do it again. Now, when you look at this, this is the follow-up, perfect blending in, beautiful case. You look at the shape, you look at the color, you look at the margins, and how difficult it is. And I'm asking you guys this question. How difficult it is for you to do a single discolored tooth with a composite veneer and get it down right the first time. Even me, when I do it directly, I may go wrong. And if I go wrong, I need to redo, I need to reprep. Okay, and this is the final outcome. So as a final case here, what I want to show you is this, how you can create a nice combination between a direct approach and a direct indirect approach. And then we'll wrap up. Now, this is a lovely young lady in her mid-20s, and she presents with this situation. She has a midline diastema closure, 2 defective class 4s. She has an endodontically treated lateral incisor, number 7. She has the need for veneering of number 6, numbers 10 and 11, and she needs some gingivoplasty. So what I do here is I do my digital planning, I do my perio recontouring, we bleach, and then after bleaching, she comes in for the restorative phase. Now, the centrals are indicated for a direct approach. Why? Because there are class 4s, diastema closure combination. And in those situations, the direct approach is indicated. I cannot do diastema closures and class 4s like that with a direct indirect technique because it will lock in. As for the others, I can. So I am doing the direct layering here. And then now I'm doing the direct indirect veneers for the laterals, the canines, and now I'm bonding the veneers. And I'm bonding them. And I'm even doing a crown, indirect crown with composites on the other lateral, on the 7. So this is what it looks like when we get done. And this case exemplifies a fantastic combination of direct procedures with direct indirect procedures to resolve a major aesthetic challenge that we faced with this young lady. Now, I have a question for you. Knowing what you know now, can you see yourself adding more composite resin veneers in your practice? I have yet another question for you. Would you like my help learning how to craft beautiful and long-lasting composite veneers for your patients? If your answer is yes, are you okay if I tell you about my new online continuing education program? So I'm going to ask Stephen to come back in because he has a special announcement for you.
All right, Newton, that was an amazing presentation. And everybody, we've been getting emails about this, and we have a special announcement because today we are relaunching Newton's online course. Composite Veneers Online. So this is being relaunched today because you're attending this webinar. You have the opportunity to join this amazing course. And with Composite Veneers Online, we've designed a 2-year online curriculum to teach dentists how to craft beautiful and long-lasting composite resin veneers for their patients. And this course, Composite Veneers Online, is taught by Dr. Newton Fall using 7 different clinical training modules, all online. And you can see the portal here. Newton's created 7 different modules for you to learn this and master these techniques. We also have a really great bonus package for you as well. So just kind of stay tuned and see everything. These are the details. So what's included with Composite Veneers Online? We have Module 1, which is Composite Resins and Layering Strategies. Module 2, which is Direct Composite Resin Veneers. Module 3, which is direct, indirect resin veneers, the concept. Module 4, which is prepless contact lenses and veneers. Very interesting module, seeing the prepless contact lenses. I think that's really cool. And he has some great case studies in this video case studies in this module. Module 5 is veneers with preparation. So how to manage those discolored teeth, because let's be honest here, Emax is not the best at managing and blocking out discoloration. I think you're better layering out a properly layered composite veneer. I think it masks better than Emax. And a lot of the labs aren't doing feldspathic porcelain anymore. Feldspathic porcelain is my go-to for discolored teeth if I wasn't doing a composite resin veneer. I don't find Emax is great with discolored teeth. I find the value lowers and it looks gray. So learning this, if you don't have feldspathic veneers, is really powerful. Module 6 is indirect restorations fabricated on flexible silicone models. This, for me, is something I really want to learn because it just feels to me like making provisionals, which I think is really something I feel comfortable with. So I'm looking forward to this. This module, Newton, is still building, so we'll have that released soon. Module 7 is direct, indirect class 5 inlays. This is super cool as well. And this module shows you a case study, video case study, the concept plus a case study. And you watch this module, you'll be able to do this in your practice the next day, as long as you have the different materials that are needed, which, you don't need a lot of extra equipment to do these kind of restorations, which is one of the big bonuses to adding this to your practice. So bonus 1 is quarterly composite resin coaching webinars with Dr. Fall over the next 2 years. It's a 2-year program with quarterly coaching webinars. So you'll have the opportunity to attend 8 different coaching webinars with Dr. Fall. He's going to show different cases at the beginning of the webinar and then look at member cases for the last part of the webinar. And then bonus 2 is composite artistry, creating anterior masterpieces. It's an online seminar, a full-day seminar with Dr. Newton Fall, showing, more than just composite veneers. This will be a fantastic opportunity to see, class 3s, class 4s, a lot of different things that Dr. Fall is known for and has taught for the last 30 years. You'll be able to experience this without having to fly anywhere, which is fantastic. Module 3, or bonus 3, is the polychromatic layering technique with Dr. Fall. And this one, he's just putting together a narration of this, but it's showing, detailed layering of the technique. And we'll talk about this a little bit more when we go over the bonuses in more detail. And then bonus 4 is Filtex Matrix Technique webinar. And this is with Marcos and Bob, who teach CMO. And I've seen this presentation previously, and it's really good. I think you'll enjoy this. So what is the investment? So CVO, Composite Veneers Online, is $29.95. There's been a link added to the side of this page for you to join us. And it's courses.phalendentalseminars.com/CVO. And you're getting all of this for $29.95. This is basically one or two cases in your practice, and you'll be able to, learn how to do this for the course and be able to do many cases over the years. So this should have, as long as you're doing the cases, an incredible ROI for your practice. But don't listen to me. Listen to what Dr. Coys has to say about this with Dr. Paul.
They do and go, how can I be like him? And so I would say, even for Bob, with Bob here or Newton here, that's a goal, right? You go, I want to achieve their status. I'm going to target them. And if I could be like them, I'm going to be in composite heaven, right? That's the goal. And so I hope that Newton, if anything, inspired you to be better, because it's possible. And that's, I think, a message that's the priceless part, in addition to the things that you did for 3 days. I thought it was pretty impressive.
So that's Dr. Coys. After Bob Margis actually sent me this video that he recorded. This was Dr. Coys talking when you and Bob taught, or Bob helped you teach, the Composite Veneers course at the Coys Center. So Dr. Coys was very impressed, obviously. He gets Dr. Paul to go there and teach. And the big message is, it is possible to be better. It is possible to be better. And with that in mind, we have a webinar membership offer for you. So because you're attending this webinar, we're going to let you join CVO and save $1,500 today. So this is available only for the next 2 hours. So once you click on that page, you've got 2 hours to decide if you're going to join CVO at this discounted webinar offer of $14.95. Or you can even join for 3 monthly payments, consecutive monthly payments of $5.55. As I said, this is a 2-year membership. You're going to receive basically 2 years of access and mentorship from Dr. Paul, which is, priceless, really. To be able to ask questions of Dr. Paul during these coaching webinars about your own case is really valuable. So again, this is taught by Dr. Paul with 7 different online clinical training modules. This is an example of what the portal looks like. And I'm just going to have Newton talk about each module and describe them for you so you understand what you're receiving with this. So module 1 is composite resin and layering techniques or strategies. So this is module 1. If you want to just describe this for us, Newton.
Of course. So this module is the foundation. It sets the foundation, the basis for everything that we will discuss in the modules to come. And what this module brings is knowledge about composite resin science and materials in a very clinically oriented way, so that you can understand the difference between microfills, hybrids, microhybrids, nanohybrids, nanofills, and what are the primary differences among them in choosing, say, handling, polishability, flexural strength. If you're doing a veneer and you're adding to the incisal and you have a patient that has a bruxism factor there, so you need to be aware of choosing the right materials to withstand the rigors of the shear stress and mastication. So that's one of the issues that we discuss, in addition to the actual optical and color properties that are required in order for us to mimic natural dentin and natural enamel, including opalescence, fluorescence, the ideal light transmission and light blockage for dentin. So these are components that you will learn, and also how to correlate these properties with the actual brands, commercial brands that are available. And you should be able to cross-check that with the system or systems that you currently are using. And if something is lacking from what you already have, I will be there for you to instruct you on how to supplement what you have to create a custom kit, if you will, to suit your needs and your goals restoratively. So, in a nutshell, that's module number one.
Yeah, I think, there's so many different material options these days. It's really good to have, kind of a guidepost for what to use where. So that's what this will really help people with, I think. So that's awesome. Module 2 is direct composite resin veneers. And let's hear about that, Newton.
Okay. Well, this is the orthodox approach. Module 2 addresses how you can do veneers to, number 1, change the form, number 2, change the color, and number 3, change the form and the color of the natural dentition. And one of the primary goals when we are doing composite veneers is to be minimally invasive in all possible ways and fashions. Why? In as much as we all do porcelain veneers, we understand that there are limitations to prepless veneer indications, although they are possible, they are feasible. But with composite resins, we can be even more so conservative should the case call for such an approach. And we can change just the shape. For instance, if the patient presents with heteromorphic teeth, heteromorphism is when you have teeth that are of abnormal morphology, and all you need to do is to add a little composite layer to resemble enamel to modify the shape and reinstate or corroborate a new shade to the existing dentition with prior bleaching or not. Then you have cases that are discolored, and then you need to understand how to prep accordingly. What sort of preparation is needed? How deep should you go? How even or how homogeneous should my preparation be? And this is something that you can apply to your indirect procedures as well. But we need room for an opaquer. We need room for a dentin shade. We need room for the enamel shades. And the layering strategies will be very precisely and meticulously described. And I'm going to give you the protocols, the step by step for you to select the materials and apply them accordingly. So you have the change in shape, change in form, change in both. That's a combination. So I will walk you through all these different clinical scenarios with lots of clinical case studies. And because I think what you are after is something that is clinically irrelevant. So everything that I'll be discussing here, guys, will be clinically oriented. So you will leave each module with enough information to apply immediately right after it or right along, even as you're studying it, as you're listening to it. So this is a super module that I really enjoy teaching because it addresses the conservative nature of the approach and the beautiful long-lasting results that we can achieve with composite veneers.
Yeah, that's great. And then module 3 is direct indirect veneers, the concept. So you can tell them about this.
Well, this is one module that really stands out from the standpoint of showing a technique that is unorthodox. And how is it unorthodox? Well, this is based on a book that I published in 2020 along with Andre Ritter. And this book addresses a technique that is originally published in the early 1990s by Nathan Birnbaum, and that I evolved on. And I've come up with different ways of using a technique that comprises and combines the benefits of both direct approaches and the indirect approaches. In other words, you will be doing veneers that are done in the mouth, applied on the tooth prior to acid etching, and then you can remove the veneer finish, polish, get super fine, highly finished and polished margins. And then you can submit these veneers to heat tempering, which will further enhance the physical and optical properties of the veneers. And then they give you the ability of doing some shade try-in cases, especially when you're doing a single tooth and you need to change the value or the chroma or both. So you can pre-visualize the final color outcome, and then you can bond these veneers on the same appointment. So the technique is so fantastic because it allows you to be the mastermind of this craft and doing your layering, getting the anatomy correct, checking for precision of fit, precision of form, precision of color, and then and only then bond the veneer with the utmost margin of fit, color, precision. So overall, it presents a lot of benefits when compared to the direct approach. And I will make certain to tell you why and when you should do one versus the other, when to do a direct veneer and when to do a direct indirect veneer and contact lens. So I really like this module.
That's great, being able to tell where and when to do the different cases and techniques. And the other thing is, again, if you submit your cases during the coaching webinars, you can ask Dr. Paul what his opinion is. Do I do a direct? Do I do a direct indirect? Which way should I go about doing this? Should I do a contact lens? So this is, super valuable to have that mentorship available. And then module 4 is maybe my favorite module. It's prepless contact lenses and veneers. I really love these contact lenses, and Newton's showing this in so much detail with case studies. Just tell us about this, Newton. This is so cool.
Well, this is the module that brings everything that was discussed prior into the clinical scenario. So we're going to have lots of case studies in which I will address from the simplest procedures, such as a single shaded contact lens. And by contact lens, I mean an extremely thin composite veneers ranging from 0.2 to 0.5 millimeter, in which we want to change the shape of a tooth, or we can do multiple teeth with extremely thin restorations that alter the shape and the shade to some extent. So you can be extremely conservative treating teenage patients that want teeth that are brighter, that are have a fuller anatomy and the arch and the smile frame. And if we have situations in which we require minor tooth preparation or teeth that are, say, lingually positioned, and you need to modify your labial contours and color to a greater extent, then we resort to what we call the direct indirect veneer. So that calls for a layering strategy that brings in not only enamel shades, but also dentin shades. And we'll discuss in thorough detail how to select the materials, what the indications are for different types of layering and veneer situations. If you're not adding to the incisal edge, if you're adding to the incisal edge, things like that. And one of the things that I really love about this technique, folks, is that once you master the protocol, and it's quite simple, but you must go by the step-by-step and understand the protocol, you should be able to do a single contact lens in approximately 12 minutes. So this is a challenging proposition that I have for you, that you learn this and then you become a fast operator in association to being a precise operator. In 12 minutes, come on, give me a break. I mean, how fast can anybody do a veneer that fits precisely, that has the right shape and the right shade in 12 minutes? And I want to teach you how to do that. And we have some videos embedded in the module so you can relate to the actual dynamics of what goes on clinically and translate that to your clinical scenario. So this is a module that you will love. I'm pretty sure you'll love this.
Yeah, it's really great. That's really cool. Veneers with preparation, discolored teeth, which I think again, you can't mask these dark discolorations very well with the traditional lithium disilicate. I don't feel. I find the value gets low. I can do it with feldspathic because they layer in the dentin powders, but with composites, you can mask really well, right, Newton? Like you
Well,
show it
exactly.
in the teeth.
Exactly. Okay, this module addresses one of the greatest clinical challenges restoratively, if not the greatest, for anyone who is a restorative dentist. It doesn't matter if it's with composites or with porcelain, and that is matching the single tooth.
Yeah.
We all know the importance of dominance for both centrals, don't we? And we all know that achieving symmetry is key to making a smile harmonious, proportionate, anatomy wise and color wise. And what I bring into this module is understanding how to prep a tooth accordingly, how to really achieve the amount of room and the homogeneity necessary for you to do the actual layer applications in a sense that you are able to block out the discolored substrate. In other words, you are neutralizing the low value and the same time you are achieving a veneer that is lifelike, because one of the issues that we find day in and day out when we see a lot of direct veneers or even indirect with feldspathic or lithium disilicate veneers on a single discolored tooth is that we tend to block out the dark substrate and we change the value, but the restoration looks lifeless. Either
Mhm.
it's gray and low in value, or it lacks the translucency that we require from the outer layers, namely enamel. So, what I want to show you here is initially how to deal with preparation, then the selection of opacers, dentin shades, enamel shades, how to layer them properly so you get the polychromatic nuances, the variation that we see in a natural tooth and mimicking the contralateral tooth. And then I will expand that to a more teeth. If you have like from canine to canine, how to deal with that, treatment planning, and all that is part of this beautiful module that is mind blowing. I personally love teaching it, and I'm pretty sure you'll love it too.
Amazing. Module 6 is indirect restorations fabricated on flexible silicone models, which is something I think is really cool and looking forward to. So maybe describe this as well, Newton. And I think the point of this is when you have bigger cases to make it like more easy for the operator when they're getting used to this is being able to do a bigger case, without doing it directly in the patient's mouth, right?
Exactly. Well, picture this. You have become familiar with the direct indirect technique. You're mastering it. You're doing a single contact lens in a snap in 12 minutes or so, give or take. But then all of a sudden, you're facing a case that requires multiple veneers or contact lenses. And it may become time consuming chairside. And what you do is there is a workflow to go by in which you take impressions and you may resort to intraoral mock-ups or even extraoral wax-ups, digital or analogic, and you should be able to treat this case um, in an interim appointment as the patient goes home, and you can do 6, 10 contact lenses or veneers as the patient is away, and you have full control over anatomy, over color, working on flexible silicone models that allow you to best get your contours without the veneers locking in. And then the workflow leads you to checking the precision of fit on stone models or printed models, if you will. But by the time the patient comes back in for the seating appointment, you have everything finished, ready, heat tempered, and they're ready to go in. So that is a very interesting possibility for those who are addressing multiple units where indicated and when indicated, as opposed to ceramic veneers. And that gives you the possibility to do the case yourself or to train a staff member to do it for you. So it's a very interesting module, and I love teaching about it. I see day in and day out, I see patients that are great candidates for this approach. So that's module 6, folks.
Yeah, and this is really for those that want to take your artistry to another level, because you look at these are these are these are composites. This is not porcelain veneers, everyone. Like, this is Newton doing composite veneers that look like porcelain veneers, or better. It's incredible. But if you want to take your artistry and your composite skills to the next level and do a big case like this is probably the way to go, as opposed to doing it all directly.
Yeah, if I may add, this very case that you see on the screen was done with only 2 shades of composite, only 2 shades.
Wow.
One that is for the incisal, for flexural strength and optical beauty, and one achromatic enamel, and that's part of the drill. So it's not that you need to spend a lot of time doing multiple layers. Sometimes with 2 shades, you can solve a problem, and it's aesthetic. It's beautiful. I mean, it blends in. So
what did you use here?
I used a shade that is a micro hybrid. It's called Pearl Frost for the incisal edition, for the add-on. And then that is for strength, right? And then I used a shade of that is Estelite Omega Milky White. It's a supra nano, excellent, extremely good handling and polishability. So, and it has that enamel, higher value enamel mimicking effect. So that's all that I used.
The color and polish is incredible. And was the first one an Estelite Omega also, or was it a different brand?
Which one?
The first layer that you did. The Pearl, was it Pearl?
No, that is a micro hybrid from Ultradent. It's called Vital Essence Pearl Frost.
Oh, okay, so that was the first, and then it was
and that's something that we'll discuss in the previous modules, is when to indicate a material versus the other, not based on brand names. Obviously, we'll be referring to brand names because we must. But we're going to be talking about the properties, and we're going to say, well, for the lingual shell, you need to have a strong material, that one that will have high flexural strength. And I'm going to give you several shades and from different brand names so that fit that category, in a sense that you may think, oh, I have that product, I don't need to buy a new one. Oh, and I can use that for that particular purpose. And that's the way it is. So we're going to be, laying it for you, a wide range of commercial possibilities for you to resort to.
Awesome. Module 7 is direct, indirect class 5 inlays, which I have to say is a super cool idea, the way Newton does this. And this module is, it's start to finish. You'll watch this. You can easily take this into your practice and do this. Yeah. So tell us about this.
We all know that non-carious cervical lesions present a tremendous challenge, not only from the standpoint of diagnosing and in treatment planning and treating them to prevent further progression, be it from stress accumulation, from clenching, as we know, and acidic erosion in combination, creating a corrosion environment, but also how to restore them when indicated. So there are possibilities that involve grafting, as we know, but there are situations that the patients will waive or even decline grafting, but they complain about sensitivity, they complain about the aesthetics, and then we are left with a clinical scenario that calls for restorations that will seal the tubuli, give back the anatomy, get rid of sensitivity, all the while being very gentle to the soft tissue. So one of the things that this technique will, in which it will be superior to the direct approach, is that it's so kind to the soft tissue that it's unbelievable. You will never see a soft tissue, a subgingival margin with scarred soft tissue, with gingiva that is bleeding. Why? Because we don't do any finishing, any subgingival finishing intracellularly, subgingivally, after the restoration is in place, which happens with the direct procedure. And I think all of us can testify to this because it's all done extraorally. And then when you bond, it's done. I mean, you don't touch the tissue. If you look at the picture on the slide, you hardly have any keratinized tissue around the premolars. And at the same time, this is the immediate post-op, folks. This is the immediate post-op. So in this module, I'm going to show you how simple it is. We primarily use one or even two shades, but for 99% of the time, it's one shade of a higher opacity composite. I'm going to give you the brand names and all that. And then you're going to see videos, clinical videos of me doing this, and also in the laboratory setting, things that you can replicate right away, but right immediately, come Monday morning, you'll be able to apply this to your clinical practice. I can promise you that much.
Yeah, that's great. And then we also have 4 great bonuses with CVO. So the first one, as I've talked about, is quarterly composite resin coaching webinars with Dr. Fall. And, the idea of this is you can submit your cases ahead of time. We'll give you a deadline to submit your cases and just ask Dr. Fall about your case and get some mentorship about your case and what his recommendations are, which is invaluable because, nobody has the experience of doing these cases like Dr. Fall does. And he's going to give you his opinion on your own cases. So we've done this with a lot of our other courses, for occlusion design, with rehab cases, for Composite Mastery Online with Bob and Marcos, when people ask about composite cases with them, even with, guided bone regeneration. Every month, Dr. Mohammed is doing a webinar where he's mentoring people about their implant cases and their bone grafting. So, this is a very powerful technique of having these coaching webinars. With this course, we're doing it quarterly because you're doing a 2-year membership. But that should give you an opportunity if you have a case coming up to be able to submit it, and we'll give you your feedback at the next member webinar. So, what do you think of this?
We will even work on selective cases that we find that are didactically appropriate. And I can do some digital smile design planning, very simple keynote, just showing you where to add to and just giving you these masks of how to implement a new morphology in planning your cases. So once you submit your cases, I will go through them and select a few appropriate ones that will be used as we discuss your case, so everybody can benefit from it.
Digital smile design. Newton actually did this with my case, everyone, and it's in module 2. The replay for module 2 was our first member webinar. And Newton, near the beginning of that webinar, in module 2, the recordings, you'll see Newton doing a case of mine and showing the digital smile design techniques. And it's very cool. So that's actually really an added bonus in a sense to knowing that to be able to increase your case acceptance. He has a really cool way of doing this in Keynote, which is applicable to PowerPoint as well, I guess, right, Newton? Did you
Yeah.
do it in PowerPoint or Keynote? You did it in Keynote, I think.
Yeah, I use Keynote. I'm a Mac guy,
Yeah.
but you can do that in PowerPoint as well.
So, with these coaching webinars, Newton's going to help you implement the curriculum because he's going to do like what he did for me and show you what he thinks you should do with the case, help give you advice, and you could ask questions. Like during these webinars, what we do is if you attend live and you submit a case, we can unmute you and you and Newton can have a conversation about the case. So it's even better because you can talk about the case together and ask your questions live and in person online without having to travel. So the other option is the other thing you can do is you can ask questions under any of the videos on the membership site. So, maybe once every 3 or 4 weeks, Newton will go in and answer questions that are there. So you can ask questions there. So that's really great too. And then bonus number 2 is composite artistry, creating anterior masterpieces. This is going to be an online seminar, probably in the next 6 months. We're just dialing in the date because there was a conflict with the original date. From my end, I'm going to be traveling with my son. So tell us about this, Newton. This should be really cool too.
Well, this is a cool module, or a bonus rather, because it discusses everything composites, from class 3s, class 4s, again, veneers, diastema closures, and I will pinpoint the precise challenges that are involved in all of these clinical defects. I've been in education for 37 years, and I have my own teaching institute here. It's called the Fall Center, and I've taught worldwide. And the questions are never different. So I have gathered a a large array of questions that need to be resolved and answered clinically, such as how do I get rid of the fracture line in a class 4? Dr. Fall, when I'm done with a class 4, I see that line, that transition. What do I need to do? Then I'll tell you, you need a bevel, and that bevel needs to have 3 distinct characteristics. And then you need to use your dentin accordingly to conceal that transition. So I'm going to give you all these approaches, all these steps for precise preparation or diagnosing first, and then preparation and layering. Class 3s are simple things. It's not because we're doing veneers that every single tooth needs to be veneered. I think the excellent operator, not the good operator, the excellent operator is those who can make a class 3 disappear without being invasive, without over prepping the tooth, and selecting the right shades of dentin, of enamel, the right optical properties, and making it disappear while preserving the sound and natural structure. That's our motto as conservative, ethical dentists, isn't it? So we talk about that, and then we'll talk about interdisciplinary approaches for firm and function treatment planning. We're going to start simple, and we will progress. Peg laterals, in combination with veneers, diastema closures, and things like that. So it's a fun module because it's a clinically relevant module. Everybody here, I'm pretty sure, are faced with these clinical challenges every single day in your practice. So it's really cool. I love teaching this.
So everybody should know, this will be a live online seminar, and you'll have the opportunity to attend live and ask questions. if for some reason you can't attend live, it'll be recorded and placed in the membership portal. So you can go back and re-watch parts of it. I see in my practice new patients coming in that have it's rare to see a really good class 3, to be honest, Newton. Most of the patients coming in, they're class 3s. They're discolored, you can see them easily, they're too translucent. There's so many different, too opaque, so many different issues with class 3s that I see where they just don't look very good, and they have leakage and decay. There's so many problems, it's crazy. So, just to solve that for people is worth the course tuition in a sense. Now, I'm not saying that everybody has that problem. It's just maybe a local problem for me that I see a lot of these patients coming in and their class 3s don't look good. And, people really, these are things that people see too. So it really makes them, unfortunately switch dentists because they get a filling on the front, composite resin that they can see, and they're not happy with that. So they come to a place where they know how to do these composite artistry. So just getting better at that, I think, is real big practice builder, don't you think, Newton?
Oh, exactly. Yeah, specifically speaking of class 3s, and one of the things, and you say maybe it's just you. It's not just you. I'm going back to my 37 years of being an educator, and regarding class 3s, everywhere, every single place I go, and I would say 99.99% of my students, the doctors, have this complaint. Oh, I see a halo. It's a translucent halo, or it's an opaque halo, or I see a discoloration, like you said. It's a problem of adhesion, but it's a problem of material selection and application. And then I'll address, if you have a very small class 3 intra-enamel, you have to use a certain type of composite. If you have one that goes into the dentin, then you have to select one of two approaches: dentin enamel combination, or just a mono opacity enamel that is more of a body. So, these are things that, if properly laid out and made into a very didactic, understandable approach, everybody can use, and class 3s will have a different perspective from then on.
So it's like you're giving a cookbook for different types of class 3s. And if you follow these techniques, you should be able to get results where the patients can't see them and they last a long time and don't get tons of leakage.
Yep.
Yeah. And if you get that, again, anterior composites, there are things that you have to do as a regular general dentist practice. And patients are coming in needing these. And if you could deliver them and they don't really see them, you're going to have a huge practice builder, because a lot of people can't, unfortunately, deliver that. So just getting better and learning to be better at this, like Dr. Coy says, it's possible to get better at all of these techniques. And having a mentor like Dr. Fall, who's taught this for 37 years, is considered one of the top composite resin educators and artists in the world, is invaluable. So that's that. That will be available sometime the first half of 2025, depending on when you're watching this and attending. We'll let you know when it's going to be. So bonus 3, is polychromatic layering technique with Dr. Newton Fall. And tell us about this, Newton, because you said you already have this recorded. You're going to add an audio to it and let us see it. It sounds really cool.
You will, well, by the time we get to this bonus module, you will have learned the polychromatic layering technique that I published in 1995. And it is a fundamental part of everything we do with our layering, be it for class 4, class 3, or veneer. So when we get to this actual bonus module, what this is me demonstrating to you the buildup of two centrals that were prepped, full prep for La Crown, with composites, in which each layer is of a different brand name, but according to the actual properties that are necessary for that particular layer. I'll give you an example. So we're going to build the lingual shell, and the material that is used there must be one that has excellent handling, excellent flexural strength and wear resistance, but it also must provide the optics to mimic the halo, the enamel halo, the opalescence that is necessary there. So I will address the use of one brand with this shade and a different brand with a different shade, but they are all very similar in terms of results, both biomechanical and optical. And this goes on and on with the Denton shades of different brands, enamel shades of different brands, and up to the final finishing and polishing strategies so that you can, as you see on the screen, you can really make your outer enamel look like the real thing. So, what burrs you use, what rubber rotaries, if any, do you use? Do we use polishing paste? We will have discussed these techniques in previous modules, right? But this is just reinforced and reiterated when we get to this here so that you understand, oh, I can choose different brand names, different products, different shade designation with similar results, provided I understand the biomechanical and optical properties necessary for each layer. So this is a cool video. It's done, and I will just be voicing over and have it ready for you to listen to by the time you get to this bonus module.
Yeah, that sounds great. It should be really cool just to see the step by step. Now, you did do something almost similar to this as a bonus when we first launched the course, and it's available in the course. But it wasn't quite this. It was cool though. The one that you did, the two veneers, I believe it was, with different
Right.
different opacities, right?
Right. No. Yeah. This is a bit more complex because
Yeah.
we're using I think up to 16 different shades and brand names.
So this is just like what you can do to take it to another level, everybody. But we do have something like this that's a little more simplified. That's maybe a good intro. That's already posted on the course. We did it as a fast start bonus when we first launched the course.
Yeah. No, but Stephen, let me go back to this. This is not meant to be discouraging in that you think, oh my God, I'm never going to use 8 shades or 16 shades. That's not the point. The point is you can use different products because there are over 70 different composite restorative systems available on the market today. Okay. Now, I'm pretty sure that all of you who are listening to me today have your preference. You have your preference in terms of brand names, whatever it may be. But what I'm going to do here is to show you that even your brand name may be part of this protocol if you use the right shades in the right way, in the right shape, in the right color. But you can, if you say, oh, I only use brand X, you should be able to use with brand X all the layers and replicate what I've done here, provided your understanding of the concept is fully mastered. That's the point. So it's not for you to be discouraged by the use of many shades. It's just for you to understand the implications of how wide this this concept is, in application.
Mm-hmm. Yeah, that's super cool. Super cool. And then module or bonus 4 will be a webinar that Bob and Marcos are going to do, Filtech Matrix Technique. And they've done this previously for CMO. And I thought it was really cool. And I think Marcos said he had another case he wanted to show. So we're going to see this, and it'll be sometime next year. We just have to decide on the date. But this is an interesting concept, and I think I'll just leave it at that you'll, find it interesting. It's totally different. I don't know. It's a digitally designed matrix that's customized for you to be able to inject in the materials and get a cool result. So this should be something that's of interest to all of you, especially those of you that like digital scanning and design. So that will be in the next year or so. So this is everything you're receiving with Composite Veneers Online. Today, you have the webinar offer of $14.95. And this is what Bob has to say about Newton, and they're friends, but, obviously he's biased because they're friends, but Bob is, a straight shooter. He tells it like it is. He really does.
I'm Dr. Bob Margis, and I'm very excited to see that Newton Fall is offering an online composite course on indirect veneers. I've known Newton for over 35 years from our days at Iowa, and this course is going to be very educational. To be able to learn from the GOAT, the greatest of all time, is simply amazing. I think you're going to learn a lot from this course. I'm looking forward to seeing it myself today, and I hope you'll enjoy it.
That's amazing. And I have one more video that Bob sent me about Dr. Quays, but the video quality is not good, but you can hear what Dr. Quays has to say about Dr. Fall again.
With Newton is not only is he at another level, he makes it look easy being at another level, which is another level above that. I don't even know if there is a level you could describe that for, but to be at that level and make it look easy is I will say this, it's not something that comes, well, I think, natural. I think you can appreciate how hard he's worked to get to where he is. You don't just, he talks about birthing the baby, but you didn't come out of the womb with composite skills. You had to develop. How do you know? I'm trying to create hope for people. To be honest, say that there is hope for us because what I've done is I remember the first time I saw Newton as a lecturer and a presenter. I was just completely blown away, and then at the same time intimidated, right? Because I don't know if I could either. But I hope that what he's able to do by showing you the steps that he gets through to get to the outcome that he did live in person makes you realize it is attainable. And the one thing I've always done.
So that was the big message I wanted you to hear there from Dr. Quays is this is attainable. You follow the systems, you follow the steps. Sure, Newton's at a different level than all of us, but you could follow the systems and the steps. And let's say you get to 85% of the level that Newton does this at. That's like better than 99% of the world. So this is what we're talking about is, it's possible to be better. It's possible to do this. But you need the recipe, the steps. I learned from Newton back in Puerto Rico at the AACD, as I said at the beginning of this webinar. It was not quite, almost like getting close to 30 years ago. This was the case I did for AACD accreditation after learning from Newton. It was, I guess it was 26, 27 years ago. So these pictures my associate took of these composite resin veneer or composite veneers back from he took these pictures a couple months ago, and this is 26-year-old post-ops. So this was my AACD accreditation case, and it looked great 26 years ago. It passed accreditation. It still doesn't look that bad for 26 years. What lasts 26 years these days? I almost feel like I could go in and repolish all of this and it would still look pretty decent, Again, this is 26-year-old direct composite resin veneers. Not perfect anymore, but, I watched Dr. Fall's training. We did a little hands-on course in Puerto Rico, and I was able to go back and replicate that and pass accreditation because of him. So, it's possible to be better. It really is. And I have a message for you that I've said for a long time with a lot of things, and that is that you can do this kind of dentistry. I truly believe that. I believe with Dr. Fall's guidance, help, mentorship, and his systems from these training modules, you can do this kind of dentistry. And our mission is to teach dentists how to craft beautiful and long-lasting composite resin veneers for their patients. Now, my case, 26 years old, it probably looked good until about 20 years. If I recall seeing her, maybe 6 years ago, it still looked better than that. It's stained a bit the last 6 years, but if we can get 18 to 20 years of good looking service out of these, that's amazing. Not all porcelain veneer cases last 20 years. So we are an AGD PACE program provider. You will receive CE points with your course participation. So this is a AGD PACE program provider approved type of online CE, just for people who have those questions. And you basically now have three choices as we get to the end of the webinar. You can do nothing. This would have been an interesting educational event for you. You can learn all of this yourself. Certainly, you could do this without Newton's mentorship and his course system. But, the easy button really is to choose to work with Dr. Fall, use his systems and coaching and mentorship to help you master composite resin veneers in your practice. And I think that is the choice that I think is an amazing opportunity for you for a pretty small investment, to be honest. So we're going to do a couple of questions. Unfortunately, we've ran long with the explanation of the course, but I think that, we wanted everybody to really understand what they're getting with this because it's a huge value. But I'm going to select a few questions that people have posted and ask them to Dr. Paul. Let's see here. What kind of burr do you use if you want to remove old composite but don't want to over prep the tooth or the enamel? Is there a burr that you suggest for that? Or what do you suggest is the best practice for that, Newton?
Okay, we can use burrs and we can use finishing discs. I like to use coarse finishing disc if I have, let's say, if I have a restoration that is on enamel as well. So I have an enamel periphery so that I don't touch that enamel. So I try to use a coarse finishing disc of whatever brand you like. And then you can use a burr. A burr, usually I'll use a carbide, a 12 fluted carbide, such as a 7901. But I think the key thing here is for us to be able to visualize where the composite is and where the tooth is. And what I do is I use ADENT's Right Light Pro, which gives me UV light capability. So I see different fluorescence. As I'm doing, I turn off my operatory lights and I only use that. So I see the difference in fluorescence. Usually composites will be higher in fluorescence when compared to enamel and dent. And so I can see that shiny surface and just follow it with my disc or my burr.
Amazing. And that's Right Light?
It's called Right Light, RITE.
Yep.
Light, LITE Pro by ADENT, ADD Dent, ADENT.
Yeah, perfect. Yeah, that is a great tip. Can you give an example of a value enamel, the brand, please?
I can give several.
Perfect.
Enamel microfill Cosmodent will have two microfill incisal light or light incisal or and medium incisal. They are different. They have different values. Being microfills, you can use something from Tokoyama Estelite Omega, Supra Nanofiller, Milky White. That would be another one. You can use from Ultradent, one that I really like, slightly higher value, Pearl Frost. Or you can even use enamel white from Mosaic. Both are from Ultradent. You can, you can use one from GC, Gradia Direct. It's white, translucent, WT, and on it goes. I mean, I could give you 20 of them. 20 more.
That's good. Just having a few. Can you bond these direct indirect veneers with heated composite like Z100, or do you use resins veneer cement?
You can, provided they're not too thin. If you have a extremely thin contact lens, let's say if you have a 0.3, 0.2 millimeter thin contact lens and you heat up the composite, as you're pressing it in, you're pressing the contact lens on the tooth, that composite, that heated composite will cool down. And as it cools down and you keep pressing to get precise fit and ooze off all of the excess composite around the margins, you may crack that veneer. It's happened before. So I don't do it unless I'm pretty certain that I have a thicker veneer, like a 0.5, 1 millimeter, then I think that would be fine. And especially when I don't want to have any color change. So one of the benefits of the direct indirect technique is our ability to do a shade try-in with a try-in paste using a luting system, a veneer luting system with correlating shades for the try-in paste, so I can modulate the value and the chroma, etc., to the extent that I want, and then just use the luting resin that is calibrated to the try-in paste. So that's one of the things that you have to keep in mind.
Yeah, that makes sense. What would you say we should look at in the occlusion to be more confident that the patient won't shift the edges? Any quick to that?
Yeah, a mutually protected occlusion would be good. If you have a class 1 canine, that would be ideal. If you always try to get your canine guidance on enamel, that'd be preferred. And but what I will do regardless, let us say I'm doing these veneers and I'm adding to the incisal edge, so I have a whole new functional situation presented therein. I will always prescribe to the patient an acetate vacuum form splint for the patient to wear overnight. So this is for 90 days. If the patient is asymptomatic, right? Doesn't patient's not a bruxer, because these will function as a protective splint of some sort. The patient comes back every 30 days, brings the splint in, and I check for any perforations, any scratches that are depictive of areas that I couldn't adjust intraorally. So this serves as a blueprint for me to adjust the occlusion or the restoration further. If the patient is symptomatic or parafunctional, it's Michigan splint all the way through to protect.
Yeah, that makes sense. And that answers another question: what kind of splint would you suggest? So that's great. Here's a good one. So say if you have a discolored tooth and you bleach it and then you do the composite veneer, whether direct, indirect, or direct, are you worried about the bleached tooth underneath not being color stable and kind of reverting and changing the shade of your restoration?
That's a great question. And the answer to that is yes. I'm totally concerned, primarily because the literature will show us that there is a high potential for relapse, because you don't know what caused the discoloration. If it was hemorrhage, if it was the endo treatment, whatever the cause, and you don't know, chances for a relapse will happen within the year. And this is reported on. So my advice is not to bleach prior to veneering. If you want to bleach, if you have a sound tooth that is discolored, bleach it, do walking bleach, sodium perborate, and as you know, with water, not hydrogen peroxide. You don't want to cause any resorption. And then you evaluate it, you follow up on it, and as you see the months go by, if there is no relapse and you see the need for further treatment, minor static corrections, veneering, you may choose to do so, but be aware of that there is a lifespan for within a year before you can get a major relapse. So don't bleach it and restore it. Restore it, you have better control over your layering. But
yes, the cases that you're doing restorations to correct the color, you're not bleaching ahead of time. You'd rather not do that, correct?
I'd rather not do that.
Yeah, that makes sense. I think that makes sense for everybody. We have a whole bunch of comments of very inspirational webinar. Just signed up for the course. Thank you so much for this webinar. So we have a lot of those. Here's a question. What can be done to improve the marginal seal when the veneers or those class 5s are finished on dentin instead of enamel at the cervical margins?
Well, aside from a precise fit that you should be getting with your finishing, with your imprinting of the material and then finishing, you are only resorting and relying on rather on adhesion, on proper adhesion. So you have to use an adhesion protocol or adhesive protocol that will first seal the dentin and create a hybrid layer that is prone to light curing prior to your luting, because you're not doing immediate dentin sealing. You can't. Otherwise, you can't flake off this material, right? As we do with Islam veneers. So what you need to do is to use a universal single-step self-etch bonding agent to hybridize the layer, light cure it. You need to have a hybrid layer that is hard. This is very well supported in papers all around. And then on top of that, you want to apply a hydrophobic adhesive, like a step 2 from Optibond FL or step 2 from Albond 3, and just to create an interface of higher pH, namely that of a hydrophobic bonding resin. But you don't cure that. Otherwise, if you do, you're going to have a problem with your fitting, with your path of insertion. So you cure the universal self-etch, and then you apply the hydrophobic, air thin it, and then you bond.
Excellent. What about if you just used 4th generation Optibond FL entirely?
Well, that for you, if you want to use Optibond FL, you're going to have to use the primer and the bonding agent, right?
And you don't cure it, obviously.
Yeah, and then you will have to cure it to have a bond strength that would be reliable. If you apply the primer and the bonding resin, which is steps, 2 and 3, or actually 1 and 2, the primer and the bonding resin, and you don't cure, you're going to have low bond strength.
Okay.
You would need to cure it. That's why if you want to stay with Optibond FL, and then you use Optibond Universal as your primer, and then you cure it, and then you apply on top of it the hydrophobic Optibond FL, which is 48% fill, but you don't cure that layer. Otherwise, you'll have problems seating the veneer.
Yeah, so the adhesive you're using as the second step. Optibond FL adhesive. So that's the second bottle 2.
Right.
Yeah. Okay, cool. Bunch of others just complimenting the webinar. One member said, I don't have a question, but I wanted to compliment Dr. Fall on this presentation. Also, I love the online seminars from Fallon Dental Seminars, and he's joined and looking forward to this course. So that's awesome. Another one said they were waiting for me to launch your course. I guess since we had you a couple of times as a guest. So that's cool.
Right. That's good.
Another question, here's an interesting one. I've seen a large number of courses showing injection molding, injecting composites. What's your opinion on this technique?
I think it's a technique that has its benefits.
Mm-hmm.
And they are primarily when the operator is not skilled enough to contour the restorations free-handed, be it direct or direct-indirect. So the operator is relying on a previously waxed up or printed model to create the stents, and then injecting will minimize the need for understanding the concepts of anatomy. So you're relying on someone else who's doing it for you.
Yeah.
And then again, you need to also take into account the fact that you need to do the technique properly with, skipping one tooth and doing two teeth and then the one in the middle so that they're not bonding. I've seen people go wrong with that, so they have a hard time getting the contacts to run the floss through. So
Yeah.
it's a technique that has its challenges. And then the final thing is, in as much as flowable composites are improving in terms of filler content and rheology, by that I mean their viscosities and things like that, they're still not up there with higher filled composites that have better properties, flexural strength wise, wear resistance, and even aesthetics. I mean, so if you want to do a single shade monochromatic restoration, injecting it to get the anatomy based on something that somebody else did for you, I think that's fine. I don't do it. I don't see a place for it in my practice, but that's just me.
Okay, cool. That's fair. Yeah, I've never done a lot of these injection molding, maybe for a provisional type of situation, but not really with the
Yeah,
final.
that'd be a good indication. Provisionals, I would, go with that. Other than that, no.
Yeah, a couple other questions. I see okay, so that's the one I just did. Here's a question. I have a young patient that has severe enamel hypoplasia. Do you consider this approach of direct indirect a great option for this patient?
Yeah, we'll talk about that too. But when you have severe hypoplasia, you need to be able to diagnose it properly to decide whether you want to do micro abrasion, macro abrasion, or altogether prep the tooth for a veneer. And that is done by transillumination. And
Uh-huh.
by transilluminating, if the lesion is superficial, it disappears. If it's shallow, intraenamel, it becomes slightly opaque. And if it's deep going into the dentin, because these lesions may extend up to the DEJ and deeper, then you will see an opaque lesion, which means you need to dig in, drill it out, and restore. So it really depends on the depth and the extent of the lesion to decide whether you're going to go one way or the other. But yes, you can restore them pinpointedly instead of just veneering the whole tooth.
Okay, that's great to know. Another comment. Thank you for a wonderful presentation. My question is there a product similar to Symphony Lab Composite, which was discontinued? Any idea
Yes.
about?
Symphony was by 3M at some point. It was a flowable composite. It was very low filler. If I'm not mistaken, it was about 50% fill. That's why it wore so much. That's why it was discontinued. It was a lousy material. So Symphony was beautiful, but it was a flowable composite. And it wore. So I did a few of those only to regret that I had done them because they wore so rapidly. And if you're talking about using a flowable lab-based restorative, I wouldn't recommend that.
Okay.
I would stick to more highly filled restorative composite lab-based material. But these are really even not available anymore because of the ceramic industry has taken over and the laboratories are reluctant to do composite inlays, onlays, or even veneers these days. If anything, you will have a CAD/CAM block being milled instead of having a lab technician do an inlay or onlay or even a tape.
For sure. For sure.
So, yeah, just use your regular hybrid composite, and you should be fine.
Yeah. What veneer cement do you prefer when you're cementing these?
There are a few that I like. There are three basically. One that I like is called Ensure Light by Cosmodent. The other one would be at NX3 by Kerr, and the other one would be Variolink Aesthetic by Ivoclar. They all have try and paste that are correlating to the actual luting resin, so I can do my shade try-in. And they have both the life curing and the dual cure versions.
Okay, Newton, I think we're almost done with most of the questions. Sorry if we didn't get to all of your questions. We will, I have an email newsletter we've started, and one of the sections is webinar questions answered. I've had different course creators answer questions there, and I'll probably get Dr. Fall to answer a question or two that we didn't get to over the next 6 months. That will help if we have common questions that we don't get to. We do have a number of comments, just people saying how much they enjoyed the webinar. Thank you, Dr. Fall. I signed up for this amazing course. Looking forward to this. Proud to be a follower of the Resin Goat since 33 years ago. Wow, this is somebody who's followed you a long time, Newton. Started here in Brazil. Thank you, Dr. Fall and Dr. Fallon. This is Edvino. I guess you probably know Edvino.
Yeah, his name is Edvino Vorniaski. Yeah, I know.
Yeah. So I guess you've known him for a long time, 33 years. That's amazing. He's followed you longer than me. I've only been practicing 33 years. So 33 years ago, I was like, didn't know you can do this kind of dentistry. I just didn't know what was out there till I started going to things like the AACD and COIS and all of that. And then it's like, wow, because we didn't have Instagram 33 years ago or any of this online stuff. So we just didn't know what you could do when I was young. The young dentists now, they're exposed to so much amazing stuff. It's just like dentistry is so much more exciting because you can see all the possibilities just watching a bunch of people on Instagram. So I think it's really inspirational for young dentists, which is great. So once again, we have a webinar membership offer. The next 2 hours, you can save $1,500 today by joining Composite Veneers online. And you're getting all of this with this course package. I think it's going to be really beneficial to you in your practice. It's basically one payment of $14.95 or 3 monthly payments of $555. And I'd just like to finish by, thanking Newton for being here and spending his time with us today. A lot of people have commented how much they enjoyed this. And I think the people that joined are really looking forward to learning from you, Newton. So thank you so much for spending time with us and putting all of this together. What do you think, Newton?
Thank you, Stephen, and thank you everybody for sitting in and listening. I hope this has been inspirational and that you have been able to take away a few pearls to use right away. And I'm really looking forward to this course and to coaching you throughout this process. One of my goals in life is to impact people's lives. And I have this as a legacy from both my father, who was a professor of radiology at the dental school, who inspired me throughout his life and his career, and also Dr. Gerald Dennehy, who is my true mentor from the University of Iowa. So I have this legacy that I want to perpetuate and pass on, and I want to see people changing their lives to the best of their ability. And if I can be a tool in this process and assist each and every one of you to get better and do better, I'm here for you. So thank you again.
Amazing. And I think you are what you're setting out to be. So thank you, everybody. Thanks for joining us. If you're not joining the course, thanks for attending the webinar. We really appreciate your time and attention. And if you've joined the course, we'll see you at the next member webinar. You'll get emails notifying you about this, instructing how to submit cases if you'd like to talk to Newton about your cases. And just let us know if you have any questions on the membership site once you get in there. So thanks so much. Thank you, Newton. And we'll talk to all of you soon. Take care.
Thank you. Take care. Bye-bye.
Bye.